Good morning to everyone in the room, and I obviously include Dr. Drumright in that. Good morning, Dr. Drumright. Now, I understand that you will affirm Dr. Drumright. Can I ask you to, sitting where you are, to repeat these words after me? I solemnly, sincerely, and truly
I solemnly, sincerely, and truly
declare and affirm
declare and affirm
that I will tell the truth,
that I will tell the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Now, Dr. Drumright, as you will understand, you're about to be asked questions by Mr. McIntosh, who I think you've previously met. You're scheduled for the whole of today. I anticipate that your evidence probably will take the whole of the day. Our timetable is that we usually take a coffee break at about 11:30. We'll break for lunch at 1, take an hour, and then sit again at 2 with a view to completing your evidence about 4 o'clock, but that may or may not be precisely our end time. However, if at any time you want to take a break for whatever reason, just give me an indication. So please feel that you're kind of in control of that side of things. Now, Mr. McIntosh.
Thank you, my lord. Dr. Drumright, I wonder if I can take your full name.
Lydia Nicole Drumright.
Dr. Drumright, you are author of what we've come to know as the HAD report. And before I start, I want to understand a little bit more about your background. So I wonder if we can go to your CV, which appears in Bundle 44, Volume 1, page 196. And it should appear on the screen in front of you. I'm obviously not going to go through your CV entirely. But what I wanted to understand is, where are you currently based?
I'm at the University of Washington.
In
Seattle.
In Seattle. Now, how is it? Did we fly you over here from Seattle, or were you perhaps in the UK anyway?
No, you did not. I was here visiting family, so I'm a British and U.S. citizen, and I have family here as well as.
Well, thank you for coming up to Edinburgh. What would you describe your specialism as?
I'm an epidemiologist. That's my primary training and specialist, and I am also a health informatician.
Now, we've heard other people describe themselves as health data scientists. How does that relate to being a health informatician?
So that's an interesting question. Thank you. Data science became a new catch-all term for people who were not necessarily what we call card-carrying statisticians. So they did not have a degree in statistics, but did data science. So I could call myself a data scientist. I could call myself a number of things. A health informatician is slightly different in that we build electronic tools, work with electronic health data, and that's the sort of stuff we do to support healthcare.
And does your professional experience include working inside the NHS in England on health data systems?
It does. So I used to, when I was at the University of Cambridge, I led Cambridge Clinical Informatics, which was established to analyze our data scientifically from the EPIC system when we put it in years back.
And what would you say is your principal research interest at the moment?
So my principal research interests are split in a few different areas. I work on epidemiological problems, including I do work with Dr. Samir Agrawal on bloodstream infections and fungal infections in hematology patients, as well as working on chronic disease development in people living with HIV, and also health informatics tools.
Your original degree, I think, was biochemistry and cell biology.
That's correct.
To what extent would you consider yourself a biochemist?
I would consider myself a biologist over a biochemist. So my background focused a lot more on infectious diseases when I was doing my biochemistry degree.
And obviously, we've had a lot of evidence from a lot of microbiologists, whether academic or in practice in the health system, To what extent do you feel comfortable getting into the territory of microbiological questions rather than epidemiological questions?
It depends on how far you want to go with those. If you want to understand extensive detail about bacteria, I would defer you to my colleague, Professor Hockey.
Yes, and so it's a joint report, and in a moment I'll come to how we might divide the work up since you're the first of the three. But what's the extent of your experience in infection prevention control in hospitals?
So when I was in the UK, my first post in academia was at Imperial, and I did a lot of work with the infection control team. So Professor Alison Holmes runs that team still today, unless she's moved recently. And I worked quite closely with them, but on research questions.
And so when we've spent a lot of time in this inquiry discussing how one investigates a potential healthcare required associated infection through PAGs and IMTs and all these sort of practical day-to-day processes. What's the extent of your knowledge or experience over that side of IPC?
Yeah, I have not spent any significant amount of time sitting in those processes. I'm aware that they exist. I'm aware that they go on. I know some of the details, but I would not consider myself an expert in those processes.
Has your work as an informaticist involved feeding epidemiological information to people who have been doing IPC work in hospitals, whether here or in America?
So that is what we were working toward at Imperial when I was there before I moved, as well as the University of Cambridge. But again, I would say the clinicians would tell us what their problems were, and we were there really to be able to tell them how we might process data and present it to them, is the extent of what I
Right.
would say we've done.
Now, what I want to do formally is identify all the various documents being read, picking up some caveats about them as we go, and ask you whether you adopt them as part of your evidence, because clearly there are hundreds of pages, and we've read them, and in some cases many times, and that's prompted the questions, but we don't want to go through them where we'll be here all week. So there's the main report, which is dated from July 2024, which is, and this is really for the record, bundle 44 volume 1, document 1 at page 5. Then you produced a response about your calculations in, which I wonder if I can look at. It's bundle 44, volume 2, document 3. Now, how did this document come about? Did we ask you a series of questions and then you responded?
This is our response to the 5 reports, and is that what we're
No, I
discussing?
think this one might be the response to us asking you what your data was. If you look at, for example, that the question 1, paragraph 1, page 80, data mentioned in relation to Queen Elizabeth Hospitals, you're telling us what the data you used were, and then you're referring to various documents which end up in the bundles.
This is your questionnaire to us.
And so you wrote this, and we've put the documents in the bundles.
Yes.
And then there's the HAD response document itself, which I think you're responding to, which is volume 5 of bundle 44, and it is at document 2 at page 20. And this is a joint document of 19th of July.
Yes.
Yes. And then after that, there is some calculations that I asked you to carry out with Mr. Mukherjee. And that is bundle 44, volume 7, document, it's page 51. And you've included in that quite a lot of extra coding and results documents which follow that. And I appreciate that I asked you the questions, and so you have some thoughts about whether the questions were good ones. But is that your document?
That is my document, yes.
And then we asked you 2 questionnaires. The first one is HAD questionnaire 1, which is in bundle 44, volume 2, document 1, if we can go to that. And that is page 12 of volume 2. Yeah. And so we asked you a series of questions, some of which we directed at just you, and some of we directed at just Dr. Agarwal, and you answered those. And you're nodding. Now, there's a person doing a transcript, and they can't see nods.
That is correct.
Yeah. And then finally, there was the second questionnaire, which came in after we got other people to review your work. And that is in bundle 44, volume 5, document 1 at page 4. And of course, that included the request that results in the response document.
That is correct.
Right. Now, clearly, there have been some changes, and there's some things that I asked you to do, which you need to express a view on whether they were the right questions to ask. But in broad terms, are these part of your evidence, all of them? Happy to adopt them as part of your evidence?
Yes.
Yeah. Now, what I want to do first is think about how you were instructed, because if we go to your letter of instruction, which is bundle 44, volume 1, document 5, page 225. No, it is page 239. It's not even that at all. Sorry, it's not. It's 244. We're in the wrong volume. It's volume 2, volume 1. There we are. That's the right place. Right. So this is a letter which we're provided by the Central Legal Office acting for Greater Glasgow and Clyde Health Board, dated the 8th of February 2024. Is this your letter of instruction?
This is my letter of instruction.
So before you got the letter of instruction, I'm assuming this just didn't appear in the post randomly. Had you had discussions with Dr. Agarwal and Professor Hawkey about the possibility of being instructed?
I did. I first had a discussion with, very brief discussion with Dr. Agarwal. We met together with Dr. Agarwal, and I don't believe Professor Hawkey was there. We met with Ash Rabello
And this, Dr.
to discuss what
this is a lawyer from the Central Legal Office.
That is correct.
Right, okay. So your letter, do we see at the bottom of the page, the last big paragraph? It says, "Thank you." Last sentence. "Thank you for confirming able to assist, and please liaise with Dr. Agarwal and Professor Hawkey as to the specifics of the statistics required." And earlier in that paragraph, it says on the third line, "A copy of the original letter to instruction to Agarwal and Hawkey is appended." So did you read the letters to them?
Yes, I did.
Right.
Well, I read whichever was appended first because they look the same.
They're the same. Can we look? I mean, I don't know which one. So let's look at the appendix to their letters. So the nearest one is page 237. So the letter describes this as the questions that are to be asked. Now, what I'll do is I'll ask Professor Hawkey and Dr. Agarwal about their letters themselves, and just focus my questions to you directed at the questions. Now, should we understand these are the questions you were effectively helping to answer?
Not all of them, but yes. So for example, the first question, are hospital water systems sterile? Professor Hawkey had done a lot of that work already by
Right.
the time I came on board. And they wanted help with the statistics and
So
the data.
That was what I was going to ask you. If we look at these questions, are there any of these questions that actually you didn't contribute to in it? Although you obviously read the results, but in terms of doing the practical drafting, is there anything I should go and direct my questions elsewhere in their entirety?
Yes, so the sterile hospital water systems, that can go to Professor Hawkey, I think.
The second one?
The second one I didn't really address either.
But then the rest of them possibly, you might, maybe what about 3? Do you think that would have been one you've been involved in, the water testing?
Yeah, no, I didn't go through any of the documents on water testing or anything like that. I focused predominantly on what the data might tell us.
Okay, so effectively we'd see that within the answers to 4
And
and
5.
definitely 5.
Yeah.
And then 6.
Yes.
And definitely 7. Right. The reason I asked that is there is a document referred to in a footnote to question 3. So if you see on the third line of question 3, there's a small suffix number 1 and a footnote at the bottom.
I do see that.
With a web link. Now, that is a document that the inquiry is familiar with, which is in Bundle 18, Volume 1, Document 11 at page 819. Now, did you read this document? Or have you, until we started instructing you, had you read this document?
And I had not read that document until you instructed me.
Because the reason that I raise this immediately is because it prompts a question. I think what it does is it describes the December 2018 perspective of Health Protection Scotland and what had happened since the start of what is known as the water incident in March. And it contains a lot of facts. And it uses the concept of water contamination. It discusses what they think is going on. And it provides a lot of context. To what extent would you accept that not reading it has an effect on your understanding of what you're looking for in the data?
I think that's an interesting and fair question. I would argue there's a positive and maybe a negative to not having read it. The first being sort of objective about the data instead of having a biased opinion before I start with the data. That's the positive side. I think the negative side, of course, is when you're trying to interpret what you see, you might want to understand what's happening.
Right. How should the inquiry, because I think it's fair to say that when we ask you the first questionnaire, I think it's question 10 and 11, or we give you a long list of documents, and then question 13 is a long list of facts. And these are everything from the DMA Canyon report through that summary into all the epidemiology that we had and various facts about the state of the water and ventilation system. And your response is, as a team, is we didn't look at that, or it's outside our remit. You'd accept that?
I would accept that.
How is the inquiry supposed to react to the report you produced before you became aware of that information, the HAD report, when it is produced in ignorance of all that context? But what are we supposed to do with your conclusions, considering they were reached absent the context?
So I guess, again, the positive comment I would make is you now have a set of data and, a set of questions from completely objective people who have not been involved in any of this. I think that that's actually very helpful sometimes when people sort of become very narrowly focused on a concept. Does it help to then learn later and interpret? Probably, and I think that's what we have done largely with you. Learned about some of these later. You pointed us to certain areas, and we can consider our findings in light of that information.
So I wondered if you'd accept that you are being asked in these questions to consider, in a sense, what would be seen in the data if there was widespread water contamination of the hospital.
That is correct.
Yeah. Did you know when you wrote the report what the widespread contamination was thought to be?
So we had some awareness. You can see in the portion of the report that was largely written by Professor Hockey that he saw CNR details about what microorganisms were found in the water. We also had the whole genome sequencing data, and we did look at those.
Okay. In terms of the ventilation system, would you accept that you were being asked to consider what would be seen in the data if there was inadequate ventilation?
Yes.
To what extent did you know what was being suggested as being inadequate about the ventilation?
In terms of adequacy about the ventilation, I think we felt that we were being asked if the ventilation didn't meet the NHS standards of 10 air changes an hour. And I think there was some discussion about HEPA filters as well.
Do you know what the state of the ventilation system is in the various wards of the hospital?
Well, I'm well aware now.
But you didn't when you wrote the report?
I think we were aware that it wasn't to standard, but we didn't know exactly the details.
Because it doesn't say that in Chapter 6. There's no discussion in Chapter 6 of what's wrong with the ventilation. Why is that?
So Chapter 6 was largely led by Dr. Agarwal. I did the analyses, or I supported some of the analyses. I didn't really get heavily involved until you asked us questions later and you wanted rates.
Right.
But yeah, I would refer you to Dr. Agarwal for that.
So just to be clear before we pass it by, Chapter 8 in the HLA report is a Dr. Agarwal product largely.
Largely.
But your work on aspergillus is you then got involved once we start calculating rates.
Yeah.
Okay. Now, so I'm not sure what the right word is to use for this, so I'm quite keen to see what you think is the appropriate phrase. But would it be fair to say that the two scenarios you were considering were widespread water contamination and inadequate ventilation?
That's fair to say.
Is scenario the right word? Or would you get a better word that's more appropriate for epidemiology?
No, I think that's fine.
Okay.
I think we can go with that.
Now, you've mentioned to me when we've consulted the concept of the counterfactual, and we've heard evidence about that from a number of people in evidence. And before we go on to look at the rest of the report, I thought it'd be a good idea to see what you have in your mind as counterfactuals that we ought to consider. And so, in order to get onto the counterfactual list, would it be fair to say that a scenario has to be not implausible? Is that a right way of putting it, or is it a better way of putting it?
I'm fine with that.
Okay,
yeah.
right. So what are the not implausible counterfactuals, as it were, that you would like us to consider alongside the scenarios of widespread contaminated water system and inadequate ventilation?
So the first one would be line care, of course. That's the first thing you're looking at when you're looking at bloodstream infections, just in general. Long before I would have had any information about them working on their line care, that would be my first go-to. And there's a mention of nursing shortages. Again, you get rushed behavior and your line care can suffer. There is some suggestion of teams not working together well. Again, you get poor handover, you get less safe care. The other thing one might explore, again, I would ask you to explore this with Dr. Agarwal, is antimicrobial usage and whether or not that's driving up certain microorganisms.
So we recap with line care, nursing shortages.
Right. Is nursing shortages a separate counterfactual? Or
I would say it is. I would say it is. And alongside the nursing shortages, I apologize, Fred, for jumping in. When they move from what I think are probably larger bays to single bed bays, that creates a problem too. You need more nurses to cover single bed bays than sort of a 4-bed bay.
Now, why do you say you need more nurses? What's your professional experience that tells you that?
So my professional experience is working with the infection control team at Imperial, and this is, and also with nursing, with the head of nursing. This is a commonly held belief, and the way they run the NHS. When you have rooms that have single patients, so a single bedded bay, you need more nurses because patients need to be in the visual field of nurses to a certain extent, need to have the nurse there responding to them, even if they're still looking after more patients. So in a larger bay, you need less nurses, is the NHS's assessment. I am not going to challenge nursing in the NHS.
So you would see, quote, nursing shortage and single rooms as related to each other?
Those are related, yeah.
Right. And then you have teams not working together.
Yes.
are we able to work out which teams you have in mind for this counterfactual? Because I mean, there could be some candidates. I'll give you some candidates. So you could have estate people not working together. You could have the higher hospital management not working together. You could have the infection control team not working. You could have the treating clinical team not working together. I'm sure there's others I haven't thought of. In that sort of text, are you looking at a melange of all of them, or any particular in mind?
I would say the entire melange really can have different impacts on patient safety and patient care.
Okay, and then antibiotic resistance, I'll discuss it with Dr. Agarwal.
Right. Just from my notes, could I just identify which teams are in the melange from your perspective?
So, and this is, I want to highlight that it isn't clear. It just sort of feels suggested in the documents that I read, but that there can be tension in infection control and the nurses and the doctors that are on the ward. There can be tension with estates and the people who are supposed to be maintaining that estate. And then less so that I see anything about management necessarily, but oftentimes this comes down from management and how management is working with their teams.
Now, I'm going to come back to these later and ask about, in a sense, the mechanisms that you have in mind that put them on the not implausible list for both those and the scenarios, and then we'll look on your opinions, and we'll try and, in a sense, break them down into manageable chunks. But what I want to do before that is to look at the data.
Okay.
Because it figures that if we look at the data first, at least we have something to hold on to if we get lost. But I think you've already covered this, but I want just to be clear. In the HAD report itself, should I be focusing my questions on you for chapter 7?
Yes.
And effectively leaving chapters 1 to 5 to Mr. Professor Hawkey, chapter 6, Dr. Agarwal, and chapter 8 as it stands to Dr. Agarwal?
Yes.
Right. I'll do that, but when we just look at chapter 7, do you recollect it has 3 parts? The first part is about water testing results, and the third part is whole genome sequencing.
Yes.
Within that division, where do I go, the middle part being the data, where do I go? Do I go to you for the middle part and the other bits to your colleagues, or how do you feel the splits?
So I am happy to answer on all parts. I may defer some of the whole genome sequencing to Professor Hawkey.
Right. Now, there may be a question of time, and I might just I might leave whole genome sequencing to the end and take a slight canter through it and put you some broad propositions and see how you respond, to leave the hard work, as it were, to the professor. But what we'll do is, if we could look at the declaration to the authors. So that's on page 151 of bundle 1. So you gave a declaration. Now, have you given evidence in court proceedings before?
I have not.
So is this the first time you've come across something like this, or is there something similar in academia?
There are similar, but not quite this legal of declarations in some of the other consultancy that I've done, which isn't the same thing.
I've got 2 questions, one of which is broad and one of which is precise. The broad question is, could you summarize in your own words what you feel the principal duties of an independent expert are?
Yeah, and I think I summarized these for the CLO's legal team. I wanted to meet with them before I agreed to do this because I wanted them to be clear in my ethical point is that as an objective expert, I'm giving an objective opinion. And if the data show something they don't want to see, that's still what I'm going to report. So there is no, so I think an expert really uses their expertise and the knowledge that they have and tries to stay completely objective. We aren't working for someone in that respect.
The precise question relates to question 6.
Okay.
Are you confident that you and your colleagues have shown all the sources of all the information you relied upon in HAD1?
So I would have said yes, but I'm going to say no now because of what your team had requested, which were data sets and other things like that, which I was happy to provide.
Because it in essence, for reasons I think you're going to explain why you did it, but for reasons you have and have explained in the notes, your sections of the HAD report don't contain tables of occupied bed days for the children, and they don't
Yep.
contain coding and calculations. And you'd accept that.
I would accept that.
Why didn't they contain that?
So they didn't contain them because normally when we show data, we want to describe it, and having just data sets are not seen as helpful when you're describing patterns of data. However, and we believe that sort of the data were shared. And so in hindsight, I would say that was a mistake on my part. I should have ensured that the data sets were all shared and ensured that with the CLO, that they had indeed shared the data with you and you had the data.
So what I want to do is move to chapter 7. So if we go to the beginning of chapter 7 in the report. And we look on page 62. Now, the questions I had about 7.1 related to what guidance exists for the Scottish Health Service in management of water systems, and whether this approach is consistent with that guidance. Is that something you feel you can help me with?
I'm going to defer you. This 7.1 was written by Professor Hockey.
Well, I think it's probably better we do that with him. So let's move over the page into 7.2. Now, the question, this is a stylistic thing, and you can tell me whether I'm being unfair. Whoever designed the headings for your document seems to have a habit of putting questions, things that look like questions, in the headings, but they don't appear in the text below. Is that something that you've noticed?
I found it quite difficult, to be honest, to get the analyses. So I did a series of analyses based on discussions that we had, and I felt it a little bit difficult to get the sections and write-ups of my analyses under the headings, but they weren't my choice of headings.
Because the question I wanted to ask about 7.2 is, now, firstly, you must correct me if I've misunderstood the process, that's sort of the logic behind this. Are you testing a hypothesis here, effectively, in this section? That the hypothesis being, if there was widespread contamination, we would see a signal in the data. Is that what the question you're asking yourself?
That was not necessarily the question. I would nuance that question a little bit, and I would say, if we look at the data and we look at the patterns of infection, could that be explained by contaminated water? So I would reverse that a little bit.
Okay. In order to answer that question, do you need to know when the water is said to be contaminated?
Yes, and it was our understanding that it was from the beginning when they moved over.
Because that's not what the HPS report you haven't read says. I would summarize it, and I rather to save time, is at the beginning, there wasn't a problem with the water. It's only until 16, 17 that people become aware of it. And if you haven't read the HPS report, how can you look for the impact of that contamination if you don't know when it was?
I would agree with that.
obviously, you've looked at both adults and children in this section. And the first thing that happens in this report, I suppose, is the sub-creation of the environmentally relevant and non-environmentally relevant groups of organisms. Is that your work or somebody else's?
No, that's mine.
That's yours, right. Why didn't you follow the classifications that had already been used?
So when we were deciding what was environmentally relevant, Professor Hockey, who is an expert in this area and has worked his entire life as a researcher and clinician in microbiology, predominantly with bacteria, went through each one. I produced the entire list of species for him. He went through them one by one and made calls on every single one of them of whether or not that is something that can persist in the environment and then potentially infect a patient.
I appreciate that, and I'll ask him about that in detail. But the sort of practical question is this. This report was produced in the summer before the third hearing of this public inquiry, some years after the HPS team had attempted a number of different classifications of organisms. And perhaps the most common split they picked, for better or worse, is in Bundle 7, Document 6. And I'm not going to do the page from memory because that's going to be dangerous, is page 219.
With apologies, Ms. McIntosh, for my notes.
Bundle 7, Document 6.
Well, no, I've got that. It was really a previous point with Dr. Drumright. Dr. Drumright gave the filter which Professor Hockey applied to your list, and it's just, could I take that at dictation speed again?
Yes. So I produced every single species there were in the microbiology data set that we received. And Professor Hockey went through each species. And based on his knowledge and also of the literature, he has a very strong command of it, as well as his knowledge of the microorganisms, decided which ones could persist in the environment. I think because the question was water could persist in the water and then would subsequently have the potential to cause an infection in a patient.
So I appreciate that he's done that from first principles,
Yes.
and I'll ask him about why he did it from his point of view. But this is just more about the practicals
Yep.
of epidemiology, because one of the problems this inquiry has to do is it's got, I've lost count now, but somewhere about 7 different attempts at this. And if we look at this page, which is from the October 2019 HPS review, for better or for worse, they spent some time reviewing the rates of infections for gram-positive bacteria, gram-negative bacteria, and what they self-defined as an environmental bacteria group, and such group where they added some enteric organisms. Now, they had excluded fungi for a reason they've given. Now, I'm not saying they're right by any means, and that's a question more for Professor Hawking. But might it have given more utility and made it easier for this report to be used if it had connected to somebody else's report as well? Because one of the problems we have is comparing apples with pears.
And I appreciate that comparison is difficult, but I'll refer to Professor Hockey, but I would say, if these are not great classifications or they're not an objective classification, then why not look at a new classification, right?
Right, we'll take that off the screen. What I want to do is to understand how you, what your sources of data were.
Yeah.
So, as I think you know from the NSS response and other people, there are lots of questions, but you're not the first person to have been asked lots of questions about your numerator and denominator. It is a theme of this inquiry. So let's think about your numerator data, your BSI spreadsheet. You had
Yes.
two spreadsheets, one for adults, one for children.
Yes, I did.
And you had, I think, 25,000 of the children, and I can't currently remember how many rows there are in the adult, but they're big spreadsheets.
Yes, they are.
Right. Now, the inquiries experts, only for the children's, the New Royal Hospital for Children, they received all the test results for the whole hospital with 14,000 rows. And they then selected from that what they wanted. You seem to have had a pre-selected sample. How did it come to be that you, in effect, didn't get to choose which infections went on your list?
So when I joined, which was later than Professor Hockey and Dr. Agarwal, there were data sets
Right.
sitting in the file that was shared, and I was instructed that those were the data sets I was to use. And the microbiology data set I was told, were from the hematology oncology patients, both adult and pediatric.
Because one of the challenges that's made to your methodology, which may be that you're the wrong person to ask about this, is that what HPS claimed they did and what Dr. Kennedy claimed he did and what Mr. Mukherjee and Dr. Mumford and Mr. Dempster claim they did, and there's a big argument about whether they succeeded, but what they all claim to have tried to do is to identify patients who were in Ward 2A, the Schehallien unit, and its successor units, and try and understand what happened to infections in those physical geographical locations. Is that what you understand they were trying to do?
That is what I understand,
Yeah.
yes.
But you're not doing that, are you?
No.
No, because it's been suggested by Ms. Cairns yesterday that effectively what you're doing is asking what the rate of infections were for people who have a pediatric hemato-oncology consultant in the children.
Again, I can't confirm if it's based on the consultant or based on the patient.
Because the data you seem to have seems to be limited to people who are flagged in the system as hematology or oncology. You're nodding again for the person doing the transcript.
Yes, I would say that that is my understanding.
Yeah, so how do you react to the criticism that creates a problem because you're no longer looking directly at the physical space, which is the subject, in the case of the pediatrics, in the interest, because people are saying, we are concerned that the widespread water contamination is causing a problem in the Schehallien unit. And
Yeah.
You're not asking that question, are you?
No.
No.
We're looking at water contamination or widespread BSI across that patient population, and that's what we're looking at patterns of. So we aren't asking the question of the Schehallien unit.
So my next question, sorry, carry on.
Oh, sorry. And what I would say is, again, this gives you more information, whether or not, it's for the court to decide if it's helpful, but it's not so narrow to the one unit.
Right. So
Just so I'm following, when you say not so narrow, you've been provided with a list of cases described as hemato-oncology cases. You accept that's accurate.
That is accurate.
But you also accept that it is not necessarily a population which relates directly to treatment in a specific location.
That is correct. That being said, if we believe that the patients are in the location they're in, and I think you're going to ask me about that too, on the microbiology report, you'll notice that most of those infections are coming from patients in those units. Same thing when we go over to the adults, it's BMT, right? So the most fragile patients are carrying the greatest burden of BSI, which is not a surprise.
Because we have a series of patients who've given evidence, and their families have given evidence of how pediatric oncology patients end up on adult wards or other children's wards and get infections? And again, you're nodding. Now, the question that I want to ask you
Yes.
is this, is there a risk by the approach that you've been given that you include those cases because they're hemato-oncology patients, but in a different context because they might be exposed to a different ventilation system or a different water system?
That is correct. But if they were on that ward to begin with, the Shehanlan ward to begin with, they were also exposed to that ward. And as we get into how someone can get a BSI from exposure to water, for example, that becomes important.
And then when we move to the denominators, there's two questions. One is conceptual and one is numerical. The conceptual is you received the denominator data set. Had that arrived before you did as well?
It did.
Right. And you were told that matched. What were you told about it?
I was told those were the denominators, right? I asked for bed days per month, per year, and I was told that's what they were for the settings that I was looking at, and for that patient population. And because it was given to me by the NHS, I took that as the truth.
Because one of the problems that other authors have got into is that they have attempted to match the occupied bed days or the admission days to Ward 2A and have found it harder than they thought it would turn out to be, and have been criticised for that. So what I'm suggesting is that if you are including patients who are elsewhere in the hospital when they have their blood test, but you're only including the bed days in the Shehanlan unit, that's what you think you're doing, then again, is that you don't.
That's not what we're doing.
Oh, right.
So
Okay.
those are not bed days for the Shehanlan unit. Those are bed days for, as I understand it, hemato-oncology patients in each of those hospitals or sectors, as the case may be for adults.
Well, then the question that flows from that is that if we look at what you're measuring, you're trying to measure the rate of infection amongst hemato-oncology patients,
Yes.
irrespective of where they are.
Yes.
Although most of them are in the Shehanlan unit, you think. And you do that by dividing by the bed days of all the hemato-oncology patients. Is that effectively what you're saying you're doing?
Yes.
Yeah. If you have one hemato-oncology patient, I mean, this is an extreme example, but I think it might have happened, who is sitting on a ward in the children's hospital where there are no other hemato-oncology patients, and you want to measure their risk, do you not need to take account of the activity in the whole ward they're in?
So normally, yes, that's the way that would be done. So for example, if they're out in, I don't know, a gastroenterology unit, let's make it very extreme, you would want to know normally in surveillance what ward they are in and their exposure there, right? So that's your denominators in that ward. But you know, I understand the limitations of the NHS where patients are put in wards that aren't part of their healthcare area.
So the question then arises is, to what extent is what we've just discussed disclosed in the HAD report, Chapter 7? The fact that you are looking not at the Shehanlan unit, but at the patients spread around wherever they happen to be.
But I believe we said that it was the hemato-oncology patients, not the Shehanlan patients. And we have tables and documents listing clearly other wards besides Shehanlan. So
you've seen the final document from Ms. Cairns in which she, at our request, pulls out the numbers from the HPS report that we were just looking at that show the occupied bed days for the Schiehallion unit and its predecessors. And she points out that your numbers bear no relationship to that at all. I get the impression that your response is, well, what is your response to that?
Well, I have a couple of responses to that. The first one is, it's quite difficult for both the inquiry, but for anyone trying to help in this space to be able to, or monitor healthcare infections, to be able to do so if we can't even get a standardized denominator, right? So I would hope at a minimum, we're talking about standardized data sets, so really important to the NHS, really important to surveillance, really important to patient safety. We could just get a standardized denominator. That being said, and the questions you're currently asking, I wonder if we are comparing the same denominators or not. So I wonder if I did see Ms. Can's document. I was pretty surprised that it was that different, given that, you know, where she says her data comes from at Health Protection Scotland, it should all be coming from the NHS. I received my data from the NHS. I just wonder if those are different, you know, they're pulling from different wards. I wonder if it's from different wards. I don't know.
Because the question that seems to arise from this is, I absolutely get that you're of the view that however this is different, it's still interesting and useful. We should look at it. And
Yes.
I sort of park that to one side and just look at the negatives for a moment. You were supplied with occupied bed day data by Greater Glasgow and Clyde Health Board.
That is correct.
They supply, according to Ms. Cairns, the Public Health Scotland data set that Dr. Kennedy and HPS used, and yet they didn't supply that to you.
That appears to be correct.
Yeah. One of the factors that happens during the story of these events is that the Schiehallion unit, Ward 2A and Ward 2B, moves
Yes.
on the 26th September 2018 to Ward 6A, unless you require a BMT room, to Ward 4B. And that is a geographical location change, and one which we're really interested to see whether we can see any consequences of it in the data.
Yes.
And yet you're not actually modelling or understanding the infection rate in Ward 2A or Ward 2B or Ward 6A in your work. You're modelling a slightly more diffuse community of patients. Is that a fair criticism?
Yeah, I would say it's a broader community of patients.
Does that have any effect on the value that we can ascribe to your number set? Your data set.
So what I might argue is that, as far as I could see, and I'm no expert on all the evidence that was provided, but of course, your team helpfully pointed me to a lot of different documents to look at. Everyone has been focused very narrowly, and as you say, because they think this is the unit that has the predominant problem, this is where they saw the water issue. Looking at the broader patient population is very helpful for context as well, I would say, because if you just look at something narrow and you have no comparisons, you don't actually know that you have an increase or a decrease or a problem. All data could be increasing and decreasing at that same rate.
What I want to put to you is that you didn't design this piece of work with that in mind, because you didn't know at the time you designed it that the interest was on 2A for...
That is correct.
So you're effectively retrofitting a positive onto the design that you did build.
That is correct.
Yeah. And this report has arrived with some fanfare, and yet you didn't know what the temporal extent of the water contamination, and you didn't know how your patients you're looking at related to the physical geography.
That is
Does
correct.
that not raise some questions about whether you designed the survey very well at the beginning, the piece of work at the beginning very well?
So that's an interesting question. I think these were the data we were asked to work with. And as you well know, when you're a consultant, you're asked to do a certain project and you agree to carry out that project. So these were the data we were asked to work with. I would suggest you ask the CLO why this data set.
Well, we can. Whether client confidentiality will prevent us being told is a different question. But I need to ask you the reason that I asked all that, which is that there are two cases which NHS Greater Glasgow confirm were linked to the water by means of whole genome sequencing. One of them is a Cupriavardis case from 2016, and the other is a 2018 Mycobacterium pseudomonas case. Now, what I'm intrigued to understand is why those two cases don't make it into your data, your exercise at all,
We do have Cupriavardis.
but not the 2016 case.
Oh, really?
And Mycobacterium pseudomonas isn't in your data
Isn't
set.
in there.
Now,
Those
you're not
are-
the only person not to have had Mycobacterium pseudomonas in your data set. The CNR originally didn't at one point. But why is it that in being asked to do this exercise and receiving a data set, the two cases that the health board accept have a link aren't in your data set?
That is a question for them.
Now, before we go to the back to the children, as it were, let us look at the adult cases and try and understand something about the case design that relates to them. We'll go to page 69 of bundle 1. So this is 7.2.3, bloodstream infections to adult patients. And this page has at the bottom a sort of summary. But before we discuss this in any great detail, you've looked at North, South sector, and adult BMT.
That is correct.
Now, did you decide that division, or was that predates you?
Predates me.
What do you understand to be represented by those three designations?
So my understanding from what I was told is those are the adult hematology oncology patients in those sectors.
Right.
And that South moved to QEUH as well as BMT, and those dates are in there, and I can recall those dates for you if you want, and that North sector remains in its location outside of QEUH.
What's your extent of your knowledge from, well, I mean, you probably know more now, but when you wrote the report, to what extent did you know the extent to which the adult BMT patients were exposed to unfiltered water in the hospital?
That I was not aware of. We were told, so if you note in the way I set up the data when I split it between QEUH and other hospitals representing those sectors, I do account for that temporary move, which I now understand BMT moved in 2015. They were supposed to go over with South, and then they moved back again. I did not know why that move occurred.
Right. So,
And that is now my understanding that
yeah,
it's due
so
to the water.
what I want to put to you is that whilst the North sector stayed in the North sector, and as far as we're told, there's no suggestions anything wrong with their water or ventilation, it seems to be uncontroversial that the South sector were in Ward 24 in Southern General, and then they move into Ward 4C. And they are exposed to the water until the filters go on. And do you know when well, you know now, but did you know when the filters went on?
We did. This is something I did not know anything about.
And the BMT patients, as you say, they're in the hospital for 5 weeks in summer of 15.
Mhm.
Then they go away and they come back in, I think, June 18,
That's
at
correct.
which point there are filters.
That is, yep,
So
that's my understanding.
does it cause any difficulty to the structure of the adult part of this chapter that the North that the adult BMT patients, apart from that 5-week period, don't appear to have been exposed to unfiltered water at all.
So in hindsight, had I been aware of that, I would have modeled the different sectors separately. And I do a little bit of that.
Well, we might
in
come to that
yeah.
in a moment. Now, Miss Cairns raised an issue with you, which I think has been resolved. And I want to go to her document simply because I think it's quicker so you can see what I'm talking about. So if we go to Bundle 44, Volume 2, Document 45 at page 693. Definitely not that one. 4040. The good thing about this week is it's always Bundle 44 unless it isn't. So that's Volume 2, page 693, please. Yeah, it's paragraph 3.2.5.1. So there's a discussion here from Miss Cairns about consultant sectors, and
Yeah.
you respond to it in your response document. What was the point you thought she was making here?
So yeah, so I think the point she was making here is that, and this is a difficulty with working with somebody else's data without speaking with them, right? Is that I had misassigned some of the sectors to QEUH. Now there is a column in that data that's QEUH, yes or no, that's the assignment, and that's not the column she was looking at, is
Right.
my understanding.
So you've misassigned something she thinks, but actually in the one you actually used, you hadn't misassigned it.
That is
That's
correct.
effectively the
Yeah, I
resolution.
double checked that.
Okay, right. Take that off the screen. What we'll do is we'll go and look at the report itself. That's 44, Volume 1. And we'll go to page 73. So I want to just check that I want to just look at a few charts and then check I understand what I'm looking at, and then ask you some questions. So if you go over the page to figure 5, without discussing what's in it, just in terms of the colours,
Yep.
who are included in the red line?
Okay. So the red line, and I apologize for this not being clear. So I have the data given to me from North, South, and BMT. So in that red line, anyone from those sectors in the data set that I'm provided who are not currently at that moment in time assigned to QEUH. So for North, that'll be for the entire period. For the South sector, that will be until I believe it's
May or
June 2015. And for BMT, I take that 2015 period, the June and July, they're over in QEUH during that period. Otherwise, they're included in the red until June 2018.
So it is a geographical split.
Yes.
And so adult BMT move around quite a lot, and South move around once.
Yes.
Right. So we go back to the previous page. The bottom of page 73, you discuss incidence of environmentally relevant organisms by QEH versus all the hospitals. Figure 5 demonstrates similar incidence by month per year of environmentally relevant organs, with the exception of both periods of both spaces having period spikes in incidence. Of note, from mid-16 to mid-18, there appear to be a series of spikes in incidence at Queen Elizabeth. However, by mid-18, incident rates in both Queen Elizabeth and the other hospitals are similar, if not slightly higher at other hospitals. And then you say, when we adjust for unrealistically small denominators over the page, predominantly from South sector, which moved to Queen Elizabeth, we see a dampening effect of the spikes, with a possible true spike in incident at Queen Elizabeth at early 2018, followed by significant low incident for the remainder of the time period. This suggests that there may have been an overall brief spike in incidence compared to background at Queen Elizabeth at this time, with constant and relatively low incidence following, and even a possible reduction in incidence from 2022 onwards of bacteria attributable to microorganisms that can persist in the environment. And we can actually see that the changed one is figure 6, which is page 75. So I have two questions about this exercise. The first relates to the unrealistically small denominators. Now, what did you do when you thought there were some unrealistically small denominators?
So the first question was I posed that to the CLO that we were working with because, I said, are you sure these are right? Unless they've closed a ward, I wouldn't have expected to see that low of a denominator in bed days. Then it was sort of like, well, that's the data you have. So I said, well, I guess what I could do is look at what it looks like every other year that's not that year in that same month, and sort of calculate an average and take a look at that and see what it looks like.
So one observation that was made is that in some months there are possibly unrealistically big denominators.
Yeah.
I mean, if we go on to page 72, just to pick one, 2014 April, page 72, that's the top up there, 5th row down, in South Sector, there's 447 bed days, which seems quite high. I mean, I don't know. And if you look down into 2022, there's a 332 in what I take to be May. Did you do anything about unrealistically big denominators?
I did not, and I think that was a fair comment by Ms. Carnes.
Now, I appreciate you might have spoken to CLO and they told you have the data you have. You didn't feel it was appropriate to ask them to contact the consultants who run that ward, who could have told you what was going on?
I was not aware that that was an option.
I mean, we have statements from those consultants which were taken while you were doing your work, but we weren't asked to do that. So would it have helped to know some context from those consultants?
It would have helped tremendously. I think that, had I designed the study in hindsight, I would have asked for all the data. I would have been aware that other people had modeled this and asked for their data as well. So I could look at data comparisons. And if we were able to talk to the consultants or the nurses that were working at the time, that would have been very helpful in understanding.
Because one of the, I suppose, the problems with this exercise is how, if we go back to, we sort of flip inconveniently, and we're not going to do this, we'll just do it in our minds, between page 74 and page 75. If we go to page 74, we have, as you described, between 16 and 18, a series of spikes in the blue. And we go to page 75, and we have less spikes between 16 and 18. Now, what's your view about what we should look at and ask questions about in these two charts?
So this was an exercise to just caution that there is what we call noise or wobble in the data. I modeled everything on the data that I received. So I did not use the corrected denominators for most of the data that I modeled.
Because there's nowhere in this section any discussion of whether any of these spikes are significant.
Yes, this is merely a plot. This has not, so later on, as you're aware, because you requested this does not have models like a GAM model or anything like that looking at whether or not these spikes are significant.
But because this is really the only bit of the adult data that posits this question, I'll ask it now. Given that we know from the water testing results, albeit not for this Ward 4C, for other wards, well, we actually know for large parts of the hospital, there were high positivity. Now, there's a debate about whether the positivities are accurate, and a witness has explained that they should be downgraded for reasons to do with the thresholds. But an argument can be presented that in February, March of 2018, there was high positivity in water testing results. Given that that's a fact of, well, it's not quite a fact, it's a series of bits of evidence we know, should we not be looking at that early 2018 spike and raising our eyebrows quizzically and wondering what's going on? And indeed followed by the drop-off that you notice afterwards.
Absolutely. I would say that if, again, I was designing this study, I wouldn't just look at water. I would look at everything that might be going on at that time period that could attribute this spike.
Right. So there might be other counterfactuals here.
Lots of them, yeah, that we've listed before.
Yeah. But I suppose in order to sort of give an advance notice of the sort of questions I'm going to ask at the end about the pediatric data, we listed those counterfactuals.
Yes.
So we've got water. We're not going to ignore ventilation for the purposes of these. Is that the right approach?
Yeah, for bloodstream infection, I would
So we've got
ignore
ventilation. We've got CLABSI. We've got nursing/rooms.
Yeah.
We've got team dynamics.
Yep.
Antimicrobial resistance. Now, do you get CLABSI spikes that just go up and go down again? Is that how CLABSI works, or is it more this what we've seen in the data set that Ms. Rogers talked about, where it's a big thing?
Yeah, it's more, I would expect it to be more of what we see in the pediatric data.
So it's spread over time.
Spread over time. They discover it, they address it. If they address it well, you see it go down.
But it's not something that happens briefly.
No.
No. So can we put CLABSI out of our minds for this spike?
Yeah, I guess so.
Yeah. Team dysfunctionality?
Depends on what's going on and how long it lasts.
It's very unfair. I know the names of the consultants. I have statements from them. They haven't been asked. But I put it to you that the sort of team dysfunctionality that you probably get a flavour of from the material, and we've had a lot of evidence about, his lordship's not made his mind up about yet, happens over a long period of time.
And that's normally what we see, yeah.
Yeah, and does that cause just a spike?
No, I would expect it not to, depending on what it is. But of course, if it's, it depends on the teams, doesn't it now? If it's the estates team refusing to do something that the clinical team wants and then somebody gives in, that's another potential.
And then antimicrobial resistance, maybe not your thing. Does it happen in spike way?
No, because antibiotics go up over a certain amount of time, is my understanding. And I had a look at Sean McBride's data.
Well, can I ask you about Sean McBride's data now?
Yeah.
But I'll do that after I've finished this section.
Yes. So it just suggests there's a pattern over a long period of time, is what I wanted to mention.
So what I'm wondering here is, I know it's a spike. I'm instantly nervous about spikes. Would that be the right approach, to be worried about a spike as a single signal?
So unfortunately, with this retrospective data, I would say normally I'd be worried. I'm a little less worried because I'm more concerned about the quality of the data rather than anything else here.
But if we take the spike and this reduction you observe, what was the word you said?
Just so that I'm following. When you are being asked about being worried about a spike, it occurs to me that the worry might be about a number of things. Are we talking about the worry being that something has happened which is demonstrated by the spike? Yeah.
Can we go to page 74?
I believe it was my understanding, just to clarify, that is what I was being asked.
Yes, so if we go to page 74, what you've said here is we see a dampening effect in the spike. So the single possible true spike in incident at Queen Elizabeth in early 2018, followed by a significantly lower incident for the remainder of the period. And I'm just wondering whether I can put this to you, that whilst one should be careful because it is a spike in some retrospective data, to what extent is this not inconsistent with a suggestion that the water in the hospital was problematic at that time?
So this is where we start getting into the biology of how someone gets a bloodstream infection from a microorganism that might reside in the environment. And that's also not super likely to cause a spike unless, of course, there was an outbreak from a common source. So typically you see a solution that they're using, injecting in patients becomes infected, or something like that. A tool that they're using becomes contaminated, and then you get this sort of single source. You still wouldn't see it go up in 1 month and then come straight back down.
Unless you put a filter on the taps at the end of the month.
Well, but this is the issue that I have with that. When you put the filter on the tap, and let's say we're getting part of the contamination by bad line handling, and they're contaminating the line from the water that they've touched or the environment they've touched, that's only going to be part of it. The predominant way patients get these types of bloodstream infections is, of course, by colonization in their gut.
Yes.
Right? And that's going to take a long time to dissipate, because the colonization in your gut doesn't go away immediately when you change the tap.
Well, indeed. And so this is one of the things that's been put to a few of the experts about enteric organisms and what you would see. And I think it will get put to Professor Hawkey, assuming I remember to do so, that if the problem in a particular patient is that they have a enteric organism that has got into their bloodstream from their gut, the frequency of those in the unit won't really change over time, because it's to do with the sort of treatments they're on, the type of their neutropenia. Professor Stevens talked about this at great length, but the nature of their vulnerability, and that amongst the cohort of the patients won't really change. So you won't see temporarily restricted increases in potentially enteric bacteria caused by gut translocation, because it's a problem that's always there, always happens, always has to be managed. And so again, conscious, it's what you call a true spike. Is gut translocation going to cause a true spike?
No.
Right. But anyway, I think I've probably dealt this one enough. I'd like to talk briefly about this paper that you mentioned from this pharmacist. Now, what I want to do to see it first is to look at a list of documents, because I'm slightly intrigued by it. If we go to Bundle 44, Volume 1, I'm going to have to do this on my computer. Document 2, page 224. So what the inquiry team did at the point when your instructions were novated over to the inquiry is we received what we rather prosaically referred to as the data dump, which consisted of all the documents which the CLO for GDC told us were in the working space that the three of you had access to. And we see a range of things. And if you see, for example, at 7, we see the first of the aspergillus diagnostic imaging that Dr. Agarwal looked at. And if we go down to, there's a lot of those. If we go to 228, we start seeing your data.
Mm-hmm.
I think it's 48, 49 will be part of your data set. Over the page, there's more of your data.
Yes.
And then we have the overview report for the CNR at 53. No, sorry, back to page 229, number 53 on that list. See on our overview report, which
Yes.
you've read. We have the oversight board timeline. Did you read that?
No. So the CNR was read by Professor Hawkey and dealt with by Professor Hawkey. I did not read those.
Did you read the GGC oversight board timeline? Document 55.
No.
The oversight board final report at 56.
No, I did not read those documents. I had a tremendous amount of work to do with the statistics and cleaning up the data.
Because if we go on to page 230 and we look at document 86, you said to me a moment ago that you felt you'd like to have seen other people's attendance statistics.
Yeah.
There's the October 2019 HPS review. It was in the data file. Did you read it?
No, I did not.
Right. On that note, we go back to page 234 to a document called page 224, sorry, to row 2, public inquiry analysis of microbial prescribing. Now, I'm not going to take you to it. And the reason I'm not going to take you to it is because we haven't called its author as a witness. I don't think you read it before these bundles were created.
I did not.
Yeah. I also know that Professor Gibson, who ran the unit, didn't see it. And it wasn't shown to Professor Stevens when he gave evidence last year on antimicrobial resistance, or Dr. Mumford when she gave evidence last year antimicrobial, and you didn't use it for your report.
No, I did not.
And so if you didn't read it, it might be interesting, but I'd have to rerun about 15 days of evidence, and it's bad enough as it is already, so I don't want to go to it.
Okay.
But what I want to suggest to you is this, is that what do we do with the fact that you and your colleagues had this folder, which you must have been going in and out of to take data, and in it were documents that are, superficially anyway, relevant?
So I believe, and you'll have to confirm this with Professor Hockey and Dr. Agarwal, I believe they read a lot more of this than I did. I was given permission to download the data on the and hold it securely, the data on the infections. And because I had to run my statistical packages and they couldn't upload them to the site they had. And so I predominantly worked with that.
Did you look at the public inquiry data in row 1?
I did not.
Because that would have given you 214,000 rows of every single bloodstream infection in the whole of the Queen Elizabeth from 2015 to 2023, or possibly 2022, depending on the version.
And to be honest with you, I would have to go back to their data file that they gave me. I'm not sure 100% of this was in that file or not.
Okay.
I don't know.
Right.
But I didn't go back, of course, when we moved over to work with you.
What I want to do now is just to look at a couple more adult hematology issues, just because I think we should probably just pick them up, which is back to bundle 44, volume 1, page 92. So this I think you've already dealt with, but it's the bone marrow treatment patients.
Yep.
So this are the patients who you have 5 weeks in the new hospital, and they go back and they return once the filters are on. So it says here, we were interested in examining single patient populations as services transitioned from another hospital to Queen Elizabeth to determine increase in number of cases for environmental bacteria, remas, which could be environmental sources of infection. What are the environmental sources of infection that you were considering when analyzing this group?
So again, this was just the water.
And if we look on the next page, we have 2 charts. The top being environmentally relevant bacteria, and the bottom being, if we just zoom down and see it, the ones that may cluster. And what I'm really asking is, what's the value of this if they were only exposed to 5 weeks of unfiltered water in 2015?
Yeah, and so that was not the information that was provided to us. So it was our understanding that we were just looking at the entire QEUH environment, and that the water overall in that environment was contaminated. So, I mean, what this happily shows is that your filtered water in QEUH looks like it's doing a pretty good job.
Because the other thing that we have, if we look at the top chart for the moment, we have evidence from the health board, which, to be fair, in submissions to lordship, I've said we should accept, and we have submissions from the health boards agreeing with me, and we have submissions from other people disagreeing with me, that by 21, 22, 23, the water management was getting much better. They were spending a lot of resources on testing, and potentially we see that in this data. Would you accept that, the right-hand couple of years?
I would definitely accept that.
So does it cause a problem that you, when you wrote this report, didn't know that? I mean, it's an arguably vague point in time, but there's a point in time when the water gets better.
It would have been very helpful to know that BMT is in a setting where the water is better. So in other words, they have a move from their other hospitals to, or from North, I guess, to QEUH, and we don't suspect there's a problem with water altogether, except for that 6 weeks. It would have been nice to compare them to South, where we do know they were exposed to potentially to
Yes,
water.
I suppose all we have for South is that previous chart that we looked at with the spike, and we've had that conversation.
So in hindsight, I would have modeled that a little bit differently.
So you might have had a chart like this, but just for South.
Yes, and been able to compare both of them, right? Because you have North who never moves.
Yes.
And you have, so all three are a nice comparison. You have North who never moves. You have BMT who moves to presumably cleaner water.
Yes.
And South that's exposed to water that might be more
just for completeness,
contaminated.
as the last question before the coffee break, if we go back to figure 6, so that's on page 75, at the point, we'll actually use the 2 spikes as our reference points. The point of the right-hand spike, other hospitals in 2022, that is North and just North.
That is just North in 2020.
And if we look at the remaining, the true spike, as you call it, in late 17, or round about the turn of the year.
Yep.
That is only going to be South, because BMT is still in the North at that point.
That is correct.
That's really helpful. What I'm proposing to do, more, this might be a good point to break for a coffee, because the next topic is to return to pediatric PSI.
We'll do that. Dr. Drumright, I hope we can offer you coffee. And can I ask you to be back for 10 to 12, please?
Absolutely.
Ms. McIntosh.
Thank you, my lord. Dr. Drumright, before we go and look at the actual charts and calculations you produce, I want to just return to bed days for one topic. So if we can go to the HAD response document, chapter 2, so that's bundle 44, volume 5, page 32. Now the top paragraph, 2B3, I think is you dealing with Miss Cairns' comment that we dealt with before. Is that right?
That is correct.
Yeah. And then I'm not to look at and 2B4 is also Miss Cairns' comment.
That is correct.
Now, at the bottom of 2B3, do you see how, additionally, the NSS report suggested that some editions of bed days may be missing in North and BMT sectors in 2013, 2014. We have double-checked this and corrected an error. Now, what I wondered about that was, does that mean that the error is corrected in the charts in the response document, having not been corrected in the charts in the HAD report?
Can I have a moment to read
Yeah,
the full
of course.
paragraph so I can orient myself? Thank you. I do recall this now. I would rely on the data that we have provided in the response document.
So the response document is the one that should be
Yes.
more accurate, right? And that was what in fact, you and I have called in the conversation the long charts that we're going to come to.
Yes.
Right, okay. And then 2B4 is you dealing with Miss Cairns. We've dealt with that. Let's look at 2B5. So what was the date range of the BSI data you were given for York Hill?
So I was given data from 2005, January, through to, I believe it's December 2022 for the pediatric.
And what was the bed data you were given for York Hill?
I was given January 2008 through December 2022.
And so how are you able to calculate incident rates in 2005, 2006, 2007?
So I imputed the dates, the bed days for the first 3 years based on all of York Hill's data.
So effectively it's an average.
Yes,
Does that inherently involve an assumption that there was no change?
it does.
Do you have any evidence there was no change?
No.
How do you deal with I think it is a fact that all the doctors and nurses who worked at York Hill effectively can't remember that long ago. And we don't have minutes for meetings back that far. And in fact, the health board, I think, have been through at least one reform since after that date. And so why is it reasonable to make such an assumption for such a long ago period?
Can we, and I don't have it to hand, can we jump to the data provided on the bed days for the
Yes,
pediatric
I think if
patients?
you give me a moment to find it,
Thank
we
you.
can do that.
Because I believe it was fairly consistent for the remainder of the time.
So if we go to bundle 44, I think it's going to turn out to be volume 2. And it's going to be document 8, and it's going to be page 94. Is this what you're looking for?
Yes, this is what I'm looking for.
So we see a repeat effectively in the bed
Yes.
days in the right-hand column over 3 years.
Yeah, and if you scroll, can you please scroll down so we see the data that are not imputed, which starts
So if we
in
go, if we can move to 2008 January to the top of the screen.
Yes, that would be helpful.
So yeah, pull it up as far as you can.
Yes, so we can see 2009 and so
Maybe
on.
look at the next page as well. Yeah, there we are, page 95. So what's the point you want to make?
So there's sort of a standard range of bed days that we see in there, and it's imputed by the average per the month. You can see sort of fluctuation by months, but it looked like there was sort of a similar fluctuation throughout time.
So
Imputing
each month is broadly similar to the other months of the same
broadly,
month
I
of the
mean,
year.
it's that's loose, but it's broadly similar. And so I thought, this was a discussion we had, said I can impute these or not.
Why didn't you put it in the HAD report?
I had probably forgotten while we were putting that report together, and I
Because
apologize.
one of the things we will come to, and I'm not going to go to them now, but I hope you'll remember this, is that in the linear progression best fit line that's in, I think, figure 22, there is a distinct downward slope in the rate of infections at York Hill. And in the chart that I asked you to calculate for York Hill from 2008 to 2015 for York Hill, we'll discuss what it means, but there seems not to have been a statistically significant trend. Is that roughly right?
We'll have to go to the chart. I
Yeah.
remember there were trends disappeared. I believe for that one, I want to say I did a 2008 to 22, but I can't remember
Well,
which
let's
one
just
I
look
did
at
that
them,
for.
because I think if I'm going to put something to you, I think I need to make sure you've seen the
Thank you.
context. So if we go to page 118 of volume 1, so bundle 44, volume 1, we'll come back to this chart many times. Figure 22, right up the top of the page, and zoom in so you just see the red. You've got a downward slope to that trend line for the York Hill data.
Yep.
Yeah, and there's no narrative in the text about it being significant, but it's there.
Yes.
And it's downwards.
Yes.
If we hold that thought and we look at volume 7, 44, volume 7, and we go to fight our way through the document. And we go to page 57. This is the same data between 2008 and 2000 and the move, all right?
That is correct. It's the same data, but I want to clarify that it's a different statistical model.
Thank you for that. What I'm wondering here is, to what extent is there a risk that the existence of those 3 years at the beginning is influencing the conclusion you reached in the HAD report that there was a downward trend at York Hill? If we go back to volume 44, that one, yes. So is there any risk that those first 3 years might influence that trend?
I would say that the risk is slight. There's always a risk, right? There's also the reverse risk that I want to mention, that if you do not have enough data, then you don't have the power to see a trend that exists. But what you can see is if you look at the peaks and troughs, so the way these models work is what they're trying to do is separate the noise in the data, which there is a lot of because we fluctuate a lot, from what's really happening in the data in terms of a trend, or when we get to the GAM models in terms of the wiggly curve. And so what you can see there is we don't have exceptionally high peaks at the very beginning.
But we have no zero.
We have no zeros.
And so the reason I'm asking this is we'll come back to the meaning later, but you didn't mention it. Why was it necessary to do at all? Why not just use the data you actually had, so 8 to the move?
In hindsight, I probably should have modeled both.
Because the length of the period from 8 to the move is what? 7 years. And the length of the period you are content to plot a line for in the children's hospital is 7 years. So what's wrong with just having 2 sets of 7 years?
So again, the more data you have in a time series like this, where you're looking at data over time, the greater power you have to detect, to look at any changes, especially in the middle. And this becomes more relevant when we're talking about the GAM models because all the data are together and it's looking at this sort of separation here between 2015 and in the move. So throwing out data always creates a power problem. And that is an issue with a lot of the stuff we see here. As I said, in hindsight, it would probably be helpful to model both, which we end up doing. Of course, I move away from linear regression models, which you see here.
Well, if you take that off the screen, before we look at the charts, there's just a question about process, because I want to get clear of understanding something. You receive these two big, well, not as big as this inquiry one, but two big spreadsheets, one for adult, one for pediatric. You carry out a deduplication process.
Yes.
I'm assuming that's done in a software package.
Yes.
It's not done manually or in
No.
spreadsheets. No. And so if we go to the questionnaire 2, which is bundle 44, volume 7, document 1, page 7, we look at question 40. We asked you a question. No, it's not that questionnaire. Sorry, I've referred to the wrong document. Give me a moment. We go on to page 8. Ah, that's why I've made a mistake. Volume 5. Page 8. Page 7 of that. Right. So, 44, volume 5, page 7. The inquiry team looked at your tables 11A to 14 in the HAD report, and before we actually had, I think, appreciated that you'd given us the environmental BSI count spreadsheet, we created a manual total because I think I was just interested to see whether there was any comparison I could make with other epidemiology I'd seen. And when we got the spreadsheet, we noticed there was a difference. So the spreadsheet you'd been provided in the spring of this year, a lot of this year after the request, was different, as this table suggests, by small amounts each month. And so what I wanted to understand, if you could explain how it was that difference came about.
Yeah.
So how did it come about?
So I write a code to analyze the data and clean the data. And I reran that code. So I was the inquiry team requested a bunch of chopped up data sets from me.
Yeah, we did, yes.
And so I reran that code, and because I was working quite fast, there were a few items that I missed. So some of that was this deduplication with organisms that have to be grouped together, the equiliquier, because they've got complex and they've got a few other things that didn't get grouped together.
So you effectively had to redo your deduplication.
Yeah.
Had you retained the code from before?
Yes. Yes, I just, so with that code, and there was also something missing, which I added in later. And this is why I was saying as well with the, it's a little bit different because there is hand counting work done with the tables for the clustering, which I
Right.
moved away from, is that there's, there were items added in later and I had different versions of the code. So I
So
had
eventually
run,
the stuff you gave us in what was effectively, I think, part of volume 2, and we looked at briefly, that was different.
Yeah, it was, yes, it was different.
And it was different because of coding
Yes.
and
it was-
changes.
Yeah. And then I provided you that whole list again with this response.
Yes, and so the charts in the HAD response document and the short ones I asked you to look at, they use effectively the third output.
The corrected,
So the
yes.
first output creates the HAD charts.
Yes.
The second output creates the stuff that you provided to in volume 2, which turns out not to match the HAD data. You realize, and he provided us the third set.
That's right.
Yeah. How would you respond to the suggestion that making such an error was misleading the inquiry?
I would tell you that that was not my intention in any way, shape, or form, and I can only apologize. I was working incredibly rapidly, as you are aware. We didn't feel like we had enough time
No,
to
you
get
didn't.
everything
You
done.
had to turn it around.
And so I just didn't, I didn't have the time to double check all those things against the other items.
Is there anything unusual? I mean, I can ask you questions about not disclosing material, and I have. And so you didn't include the occupied bed day data in your original report. You didn't include the tables that show the instance in each infection by month in the original report. Now, as a lawyer, I can say, well, that's not consistent with what you said in your declaration.
Right.
But as an epidemiologist, what's the practice there? Would you expect to include this stuff?
No, you do not provide any of that stuff. You provide the summary data so that people can understand the data. Raw data is considered not very understandable.
Now, we received from various people submissions based on what the original report says. And we no doubt will have submissions and evidence about what the second version has. And the middle report caused NSS to say various things they said in their document, and the CNR to say things, and Dr. Mumford and Mr. Mukherjee to say things. How are we supposed to... Is there anything wrong with effectively what you've done? Are you stepping outside the bounds of a normal epidemiologist by not including this stuff, making what could be described as these errors?
So no, I would say that is not the case. So in normal epidemiology, we produce our reports. These types of errors that are small are considered wobble. If it had been made clear from the CLO that we should provide data sets and provide code and provide everything else, we would have been happy to do that. So it is very normal in epidemiological practice to make data sets and code available at request.
Thank you. Now, what I want to do now is to step into the charts. Now, just to explain to you what I'm going to do, and what's the benefit for the Lordship and the colleagues in the room, what I'm proposing to do is to start with the HAD report,
Yep.
at the end of the chapter 7.2, after the clustering section, walk through the various charts, but not the conclusions paragraph bullet points, then go to the response document, look at that, look at some of the commentary at the time, but not resolve any inconsistencies, and then work our way through the ones you produced at my request. And when we do that, pick up any anxieties you have about the questions I asked, and that'll be lunchtime, And then after lunch, I'll try and ask you what it all means. And then if we still keep going, we'll do Aspergillus 3 o'clock in the afternoon. That's the plan.
Okay.
Okay. So let's go to HAD report, which is volume 44, volume 1, page 115. And you have a chart, figure 19. Now, one of the slight problems of reading the report is that the charts don't always appear in exactly the right place compared to the text they relate to. So is the text for this chart following below it in the page?
It will, in the paragraph that discusses it, it should reference the tape.
Or is it actually back?
No, that is the clustering. There.
It goes back to clustering. So the reason I ask is, if we look at figure 19, and over the page onto page 116. In fact, let's get the beginning of the sentence. So we'll go back to page 115. It's a long sentence. So 5 lines from the bottom. This is just seemingly discussing figure 20, this paragraph. It says, we can observe 2 exceptions to this, where in late 2006, early 2007, there appears to be a more significant reduction in environmentally relevant organisms than there are not environmentally attributable. And again in 1516, when the patients are moved from York Hill to the Queen Elizabeth. However, this does follow the pattern that is observed directly before the move in early 2015. This type of difference in BSI pattern could be attributable to a wide range of factors, including changes to antimicrobial policy, capacity, and laboratory services. Is that a counterfactual we ignored at the beginning? Or do you want to add it to your list?
Yeah, I think so. Along with, I mean, it starts getting mixed in with line handling, but contamination of the sample, right? When we're talking about non-environmental microorganisms, you can easily contaminate that sample.
Policies on testing for BSI, natural patterns of microorganisms and attributable environmental factors, as well as many other. In historical data, without extensive volume of additional information, it may be difficult to determine likely cause. Now, we're going to come back to all of that after lunch. And then it says, while it is unclear what may be driving these 2 lower troughs in environmentally relevant BSIs compared to other types of BSI at these time points, it's unclear that environmentally relevant BSIs largely follow the same patterns, those that cannot be attributed to the environment over time. Now, I'm assuming this is based on looking at figure 20, which is below.
It is based on figure 20.
But I suppose if the troughs are in the environmental lines, which are blue and red, we'll also see them on figure 19, without the non-environmentals there as well. Go back to figure 19 on page 115. Now, 2 questions arise. Is the trough you have in mind the 2 0 months around 2007 on chart figure 19?
Yeah, that is correct.
Yeah, and then the other trough is the slightly more than 2 0 months in late 15.
Yes, when they move.
When they move. Now, so 2 questions is, what, if anything, should I have as in a form of concern about the fact that that first trough sits in the period when you have imputed the denominator? Does that cause me any reason to be nervous about relying on that trough as a thing?
So I am not nervous, because if we look at this data set, so that was a comparison, right, between the environmentally attributable and the non-environmentally attributable. You can see more of those troughs in the York Hill data, for example. In 2000, and go ahead and look at that 2012 month one. There's some there.
Yeah, there's another one in 2009.
Yeah, and there's one in 2013. You can see them. So the data from 2005 through 2008 largely look similar, troughs and peaks to the data throughout. You have bigger peaks in 2008 and over in 2012-13, but
You're shrugging, is what I'm just saying at this point, because the transcript lady can't see shrugs.
sorry?
The transcriber can't see shrugs.
Oh, I see.
Yes. So when you shrugged theatrically at the point you said those two things, I thought I should say it.
Yes, there's it looks very similar.
So the point that's been suggested by NSS, Ms. Cairns particularly, is that another feature of this chart, which is worth saying, I'm assuming blue is not BMT, it's actually, this is pediatric data.
Yes, this is pediatric data.
Blue
I
is
apologize.
RHC and north is York Hill.
Mhm.
She observes, and others do too, that in York Hill there are repeatedly months with a 0. And in the New Children's Hospital, there are months with a 0, and then there was a long period of nearly, but not quite, 3 years, when there are no zeros at all. And then the zeros, after a little flurry, start again. And that the absence of a 0, because you'd expect zeros, wouldn't you, if it was random?
Yes.
Is there anything we can take from the fact that the only place where there are no zeros is in RHC from, what is it, mid-16, possibly second quarter 16, towards the end of 18? Is that significant in any way?
So with the data that you're looking at here, there's no test for significance or anything else. And when you split the data set, and this is going to become important later, when you split the data set and compare it using a linear regression model, that does not come up or appear as significant. When you use the GAM model, as we'll look at later, you can clearly see that there is something going on there.
I think the point that I think was being made by Ms. Cairns was in fact simpler than that. It was simply, if you have a random variation, you will always get zeros, because that's the nature, often get zeros. But the absence of zeros is something that we should ask ourselves, why is there an absence of zeros for the best part of the 3 years? Is that a question that we should even be asking?
I think it's a good question. I think it's a fair question.
Well, we'll come back to that after lunch. What I want to do is to go back to figure 20. Now, because, of course, figure 20 is quite hard to read, I noticed you then produce an non-environmental chart. And that is on page 117, figure 21. Now, it doesn't say in this report whether these two best fit lines are significant, are they?
The first one is not, and the second one is, as I recall, if I'm recalling correctly.
But why doesn't it say it?
I apologize for that. I don't know why it doesn't say it.
Because in fact, one of the oddities of this inquiry is it's not actually until
Later.
Well, you do it later on in this report. There's a mention of statistical significance, and perhaps prompted by that, we start asking. And you and Mr. Mukherjee have both, in different ways, attempted to understand statistical significance and reported numbers. But there's nothing in here that reports numbers.
No. No. And I think this was largely because there was a lot of interest. I was, later on, I'm guided by myself. Here I was guided by other people in demonstrating visually and testing less to keep things simple. I decided not to do that anymore.
Well, if we go on to the next page,
Yes.
page 118, we get to figure 22, which we will come back to. We've been to before. Are either of these two trend lines significant, linear regression line?
I would have to go back and check that.
Because the question that was raised in the NSS response by Ms. Cairns was that she felt that there was something that might be going on in the blue line between 16 and 19 that required further investigation.
That is correct.
And that's okay. And you would agree with that?
I would agree with that, and I followed up and did that.
Right. Now, what I'm not going to do now is look at the bullet points that follow at the bottom of page 118, 119. I want to come back to this afternoon because I think they fall in the category of what's going on here rather than the data.
Yeah.
What I'm supposed to do now is to move on to the to the response document. So this is volume 5 of bundle 44, and I think we're starting on page 42. Now, I think this may be a simple case of mislabeling, but it possibly needs checking. So somebody raised this. So figure 2E.3 is described as a monthly incident rate for BSIs attributed to environmental microorganisms. Could it actually be non-environmental microorganisms and be mislabeled?
This one that we're looking at here?
No, page 43. Sorry, this chart here. The reason I say that is if we go back to 44, page, volume 1, page 117.
Yeah.
Page 117. Yeah.
Yeah.
So go back to volume 5, page 43. Could that simply be a mislabel?
It could be a mislabel. It certainly looks like the environmentals, doesn't it?
Yeah.
The non-environmentals.
But in any event, this doesn't have regression analysis.
No.
It's just a plot.
It's just a plot.
And in fact, the chart that would, in a sense, most supposed to be here should effectively be figure 22 from the previous document.
That is correct.
Adjusted by the small adjustments that you say you made.
That is correct.
Right. And so if we, staying with the pediatrics and the environmentally relevant, go to page 50 to page 2F3. Now, what I want to do here is to understand, firstly, what the spots are and connect it to what we've seen before, and then understand why you did it and what you take from it. So, but not actually resolve any questions. We'll resolve them at the end. So the spots, are they, in theory, to some adjustment, the same as figure 22?
Yes, they should be data.
Right. And they're monthly totals?
Yes.
And in fact...
not totals, rates.
Right, sorry.
For 1,000 bed days, yeah.
And we can go, to return to our previous conversation, we have the 0 months along the bottom. We can see them and we can see the gap I've just discussed with you.
Yes.
Right, okay. So what prompted you to try a different sort of best fit line?
And that was Miss Can's comment about how linear trend lines may not show what we want to see. And I agreed with her and thought about this quite a bit more, which is pretty standard in epidemiology. You show people something, you talk about it, and they come up with an idea that's very compelling. So I went ahead and produced GAMS. Do you want me to describe what GAM does?
I'd like to try and understand GAMS by reference to a feature on this chart.
Okay.
And maybe it'll be efficient in time to do both at the same time.
Okay.
So when you look at, so what's the blue line on the chart?
So a GAM is a generalized additive model. So you're effectively adding models onto each other here.
So what are the models you are using at the linear stage? And
so a blue line is a generalized linear type model. So remember, we have multiple models in here that are additive. So when, for example, the red line and the blue line match, it does actually collapse down to a generalized linear model. So what you have is a linear component to your data, which exists in this type of data.
Is there a trend?
Is there a trend? Is it going up or down?
Right.
Then you have what was called the smooth line here, and I kid you not, the technical term in statistics is a wiggly line that you fit. And the wiggly line tells us if that trend is followed in a linear way or if it's followed in a flexible fashion. And then you have a third line, which I haven't shown here for, but you might want to talk about for completeness, is a seasonal trend line. And that just makes a mess over the top.
Yeah, because it's every 12 months.
Yeah.
Now, the colors, the shading, what are they showing us? Start with
So-
the blue line shading.
So the blue line shading are the 95% confidence intervals around the dark line, which is the point, so the fitted point estimate for every single one of those.
So what
lines.
does it mean to say that something has a 95% confidence interval, assuming, for the purposes of this answer, that we have no statistical knowledge at all?
So when we fit a point estimate, we're saying we believe this is the estimate based on the data, right? We believe this is the estimate based on the data, but there's always a but. With 95% confidence, that could fall between these two lines. So if you look at the outer edge of our
Yes.
confidence interval, the true point estimate, because we're sampling, we're not taking the entire population, could fall between those outer bounds.
So the true position,
Yes.
if you were to pick it at any point in that period, is 95% of the time going to fall inside those two lines.
Yes.
And is 95% a conventional assessment of
Yes.
sufficiency?
Yeah.
Right. Does it work similarly for the pink shading?
Yes, it does.
Right. Now, because it may become relevant later, is there anything important we take from areas where the two shadings overlap?
Yes, so what that's saying, and particularly this becomes important when the pink overlaps entirely with the blue, right? What that's saying is both of those components are telling you the exact same thing is happening at that point in time. So when we look at sort of the data up until 2014, I would say, both those lines are following each other, which means we're seeing the same trend.
It's a linear trend.
It's a linear trend.
Right.
And then we see a deviation from the linear trend. And when we see that, whilst the linear trend is still valid, so if that was significantly decreasing, it's still significantly decreasing. However, we believe the pink line or the red line that it actually went down, came back up, and then decreased.
And just at the end on the right-hand side after 2022, is there any point about the overlap there? Does that tell us that we're back to a linear trend potentially after 22?
Yes. Yeah, they're back to linear trend, but you can see that red line starting to dip down. I don't know what would happen if we had more data.
And this is the question that I don't understand at all, and I'm trying to get an answer, and I'll try and answer it. You've observed in the following paragraphs that the dip that happens below where the red line goes below the blue line, where the bottom of the dip, and we might zoom in a bit just to make it easier. There we are. The bottom of the dip is what, mid 15-ish. That dip starts in early 14.
Yeah.
And after lunch, I'm quite keen to get an answer to the question I'm about to ask, but you might want to discuss whether it's a good question now. I suppose one reason the dip starts in 2014 is because something happens in 2014 that causes a change. That's one possibility. Would you accept that?
Yes.
Yeah.
I would
Is
accept
the
that.
other possibility that effectively the line is trying to get down to a point when there are lots of zeros and starting early to smooth it out?
That is also a possibility. So we are letting the data dictate what is happening. And after lunch, I can talk about sort of the way the model is set up is we want it to be responsive to rapid changes, this curve. So we've chosen features that allow it to be responsive to rapid changes. And it could just be that set of zeros that are pulling it down.
And we might look at other things that you've done that might help us on their territory.
Yes.
But we'll do that as we go. Now we come to the peak.
Yeah.
Mr. Mukherjee hated it whenever I use the word peak. What's your attitude to the word peak?
I'm all right with it.
You're all right with the word peak. Okay. So obviously a peak involves a change of direction in trend. From just looking at this chart, are we able to tell when that change of direction happens, or should we be nervous about temporal fixing it at what looks like just after Christmas 2017?
So what I would say about that, and note confidence intervals around it, we have a rough idea of when that is happening.
Yeah.
So it's not happening in 2014 or 15. It's definitely happening sometime in 2016. But to say, well, I could go through and count, what month that is the accurate month. I'm going to be a little bit more relaxed
And
about
you
that.
might think you have, a year or more of a possible period when it's changing, but we're really being very vague here.
I would say, no, I would definitely say that's changing in early to mid 2016. So it's not, I
The
would,
change to go down again.
oh, I'm sorry, going up. And then we're talking about going down now.
Yeah, when's it going down?
So sometime it looks like from this, but you'll see I did a change point
Yeah, you did. We're gonna
analysis
cover
as
that.
well, because modeling data in multiple ways, if it's showing you the same thing, that really helps confirm what you're seeing. So here, the peak is at January 2018 and the downward trend happens
Then.
directly after that.
Right. Now, what I think I want to do now is to look at the non-environmental bacteria just as an aside,
Yeah.
so that we can pick it up in order. So page 51. So just in a sense to put this in context, this is in fact the same data as page 43.
That is correct.
Albeit 43's got a different label on it. Right, okay. So you've discussed what the lines are trying to do. What do you see in terms of points when things change in this chart?
Yeah. So I guess the other thing that I should add for completeness is each of these lines has a statistical significance value on
Yeah.
it. And if that red line, because we'll see this later on,
Yeah.
is wiggly, but it is not statistically significant, you shouldn't believe the red line.
Yes.
So I just want to make that clear.
So what about these two lines?
Yes.
Are
And
either
in-
of them statistically significant?
in the previous graph and in this one, they're all statistically significant. I just want to make that clear.
And so we have, when's the
So
point when we have an upwards and when's the point when we have a downward change?
yeah, so just before January 2014, this starts going up and it peaks what looks like maybe March 2017. Roughly, it's just after that January 2017 line. And then following that, it starts dropping.
Now, I should have asked a question about the previous chart. I asked you about the drop below the line, whether it's the chart trying to reach a particular group of zeros. I suppose it's harder. There's a less obvious little group in the corner here. But is the upward trend in this model attempting to get up there to catch the tops? And is the dip down happening because it's desperately trying to get down to the bottom right-hand corner by the end? Is there any of that going on in the model?
So the way these models work is they're smoothing that information at the top. And remember, I said that they're trying to account for noise, right? So the more noise they can see over time, the better they can account for it, because they can say how much noise is real. And so it is going up because you see sort of, if you look at your points in that time period, right, you see very little below the blue line and you see quite a few above the red line.
Yeah.
So that is a very smooth pulling it up. The lower end that you're talking about
In 22.
in 22 also looks pretty reasonable to me. There aren't a lot of zeros there and there is a lot of data falling down there. So I feel like there is a lot of data showing the same pattern in these areas.
I'd like to go. Remember, I asked the question about trying to locate the change points in time, and you suggested it's somewhere in the confidence interval shading.
Yeah.
Now, I suppose I could ask you about the peak at the beginning of 17. Where are you comfortable in describing that peak happening at the point when it begins to go down again?
So I guess what I would do is if we want to look at the change point analysis, I would think about it could be from where the change point analysis sets it, or it could be from where this sets it. And
Well,
there
we'll
has
do both. So from this one,
Okay, from this one, I would say that you've got your peak, and I'm gonna call that probably March. It might be February. I have it listed on
Yeah.
here because I had the program provide that, is where you hit your peak, and everything after the peak is down.
right? I think you said March in
March, perfect.
on page 52. The rise point. Now, you didn't, I think, say in the report. Oh, you have August 13 as the rise point.
That looks correct from what I'm looking at here.
I may have misunderstood something you were saying about the confidence interval shading. So I want to just see. Does the fact that the change, I'll rephrase that, the smooth line takes a rather gentle rise compared to the previous one, less abrupt, I suppose is the better word. Does that cause the period when the change might be taking place to sort of widen in time from left to right across the chart? Or I'm imagining that.
No, it is wider.
Yeah. So it's what's the sort of range of dates for that upward peak? I mean, August is obviously the center of it, and that's what you've written in your report. But what's the sort of range of dates
So
for?
just to clarify there, you accepted from Mr. McIntosh that looking at the upward change, it is wider because it's a less steep curve.
That is correct.
Did you accept what I?
I'm
also-
just double checking that, Lord. Yeah.
Okay, right now.
So if it's wider in time potentially, and you've in the report identified August 13 as the upward point, does this have a range of possible points, or is it really just August 13 from this chart?
From this chart, it is August 13. What I want to be careful about is what reality is, right? So based off of actually any of the statistical models, I am not going to claim that reality says it's that exact point. And that's because statistical models work with the data in the ways that they do with all their underlying assumptions and the ways they move. So, was that pulled up slightly later? Probably not slightly earlier looking at the data. Maybe.
Well, let's look at your attempt to see what the data told you. So on page 52, the whole page for this one, you tell us in 2F.18 that you attempted an exercise. Well, what was this exercise you attempted that you illustrate in F?
Okay, so this is a different way to model what we were looking at before. Right. And you want to use multiple models because those give you more confidence in what you're seeing. If you use two different modeling techniques and they give you two different answers, you should be very suspicious about your interpretation of the data. So what this is a change point analysis model. It is the other ones were negative binomial models. That is the family. So when we fit a general linear model, we have to specify families and links. And a negative binomial deals with lots of zeros so that they are not causing a problem in your model, or lots of extreme events, I should say. And this is a Poisson, which is a standard statistical model for count data. Negative binomial is a form of a Poisson model, but it's a special form of Poisson model. So I can't use the negative binomial model to do the change point. I have to use the Poisson. It just doesn't work in there.
Now, you've identified some change points here.
Yes.
Before we look at them,
yep.
How significant are they?
So these are all significant change points. So in a change point model, when the model calls a change point, that is significant. So what it does, this is a very different type of model. It says, I can call this incidence rate the same, right? Given all this variation, I can still keep calling it the same. And at the point it can't do that anymore, it
changes.
makes a significant change.
And so what you have is you have a rate of 5.5 until sometime in late 10, steps down to 2.8 until sometime in late 16, steps up to 6 until some point in late 19, and steps down to 1.8.
That's correct. And those are the average, right?
Yeah.
Yeah.
And I just wondered whether, if we sort of flick back to page 50, I remember your evidence was that in the first period, sort of 4 to, I can't think you might well have said 13, it's a linear trend down. And then we have this feature that you've seen. If we go back to 52.
And you see that there.
Is effectively, can we see something similar happening here?
Absolutely. So you could, and actually, you know, it's just good as an illustration. I don't want to reopen this can of worms and talk about it, but Sean McBride's analysis also did a change point analysis, and you see, and he actually like attached them.
Yeah.
And you can see that same trend that you see on his decomposed trend line, which is what we're looking at here.
And in terms of the dotted lines that show the change steps, should they perhaps have confidence intervals on them? Or am I mixing my metaphors here?
You can't get confidence intervals on these.
Seems a nice idea. If we go over the page to 53, you did the same thing for the non-environmental.
I did.
Now, and if we sort of flick back to 51, just for the purposes of having it in our minds, do you see any connection between these two analyses?
Yeah, it looks the same to me.
How would you describe what you're seeing in the two, now that you've seen both?
So we see this downward trend to begin with until, you know, this time period in late 2013. It goes up, you have this peak, it comes down, and then it drops below that blue trend line, and you sort of see that when if you flick back over.
So just to sort of recap what we got to at the end of this section, I'm going to put something to you which I think is summarizing your position, but then I want you to tell me if I got it wrong. That in respect of the environmental, there's a linear downward trend at York Hill, and then there's a peak in early 18, and there's something happening between the two, which may involve the rate starting in 14, or that may be a feature of the GAM. We have to look further to find out more. Is that broadly?
So sorry, I lost you when you said something about dropping in 2014.
Let's go back to page 50.
Are you talking about the dip, early
so
dip?
that basically
Yes.
you're saying there's from the beginning of that chart to 13, we've got a linear downward trend, not very steep, but it's there. And then there's a feature that involves a peak in early 18, and the join between the two seems to involve a dip starting in early 14, and there's two possible things going on. One that actually is starting then, and the other is the data is actually just creating a smooth, and we have to think a bit more about that.
Yeah, and then what I would add to that, I would agree with what you're saying, and what I would add to that is all those zeros, that line is just following what it sees in the data. There are a lot of zeros there.
There are a lot of zeros in that.
Yeah.
And then if we do the environmental one on the next page, that's page 51. There we are. No, page 51. Yeah, I think you were there already, that's why. In what way is the pattern similar or different that we're seeing between these?
Yeah, so we clearly see the rise in infections happening earlier.
Yeah.
So they're happening already at York Hill.
Yeah.
And they're continuing on at when they move the children. And they're coming down earlier as well.
Right. Okay.
But persisting for longer, right? That peak is tighter.
It's a flatter, well, not flatter, but it's a wider peak.
That's right.
Right. Now, what I think I need to do is decide. I think I'm going to pass over clusters for a moment.
Okay.
Because I think we'll come back later and do some of what I've described as your joint work with Mr. Mukherjee. Now, what we decided to do as an inquiry was to ask the two of you to meet. I don't want to have the two of you discuss your conversations, because the question was, could you agree?
Mm-hmm.
And you actually didn't agree ultimately on a single report, but that might have been down to the lack of time. So I want to look at the two things you produced from that conversation. And I'm working on the basis that the conversation was helpful, but you're not going to tell me how. So sort of my
That's fine.
basically
Yes.
that. So if we go to volume 7, and we go to document 4, page 51. Now, you helpfully produced a lot of this report, and it contains, firstly, I recklessly asked you the Asperger's questions first, and secondly, you included a lot of calculations, I think possibly having been challenged about not doing it before.
Yes.
Yeah. So let's pass over Aspergillus and go to page 57. Now, I think this is the point when I ask you to express your views on the very nature of the exercise I asked you to do. So I asked you to effectively attempt some form of trend analysis for 4 time periods. So that was York Hill from 8 to the move,
Yes.
RHC from the move to the date we suggested, which was the decant from 26th of September 2019, which some people seem to think is important, and from that date till the opening of the new Schehallien, and then nervous those periods might be too short, the whole period at Children's Hospital from the move till the opening of the new Schehallien. Now, do you have any concerns, or are there positives and negatives of doing this exercise?
Yeah, so I think I'll start with the negatives and why I didn't do this in the first place. So the first negative is that when you start cutting up the data, you have decided when the change point should occur. You're not letting the data tell you when it's occurring. So when you do that, you're imposing sort of an a priori belief on the model, and you're preventing the testing of something happening in there. And I show that in the later models where we test that. So I can sort of say, yeah, I can compare that this is, let's just make up a hypothetical situation. I see a downward trend in this chunk. I see an upward trend in that chunk. And you're hypothetically imposing that they have a relationship. When you keep the data together, you can actually test that relationship. So when you cut it apart, you impose changes that may or may not be real, and you also eliminate your ability to do high quality testing on it. The third thing you do is you reduce your sample size. And so remember I said the longer time period we have, the more the model can see the noise and separate the noise from the reality. And that's actually what we want the model to do. The other thing that happens is there's less power on the ends because we don't know what's going to happen in the future, or we can't see what happened further in the past. So it has a harder time picking where the right spot is on the ends. And so your power comes in the middle. So if you cut it right where everyone moves, you can't actually see the dynamics that occurred when they moved.
Are there any positives?
Just before we move to the positives, I wonder if I missed the second negative. Your first negative was if you cut up the data, investigators
are imposing the belief of when the change
it was
occurs.
the point that comes after that
is that you can no longer test for that like a sudden jump or something in the data, where you can if you leave the data intact. Right? You're just sort of comparing two things, which isn't a proper test. And you can say, I group this and I group that, and you can put a test on it, but that's not really a proper test. That's not what we want to do in statistics. We would rather test it as one unit. And then the third one is that we lost our power, and there are two issues about losing power in there.
Given your concerns, and if we go to page 118 of volume 1, why did you put trend lines on the 2 hospitals on 118?
So this has been an evolution for me, obviously, in working on this report. And I modeled this very differently. Again, here I was saying, well, this is a pretty standard way of modeling things. You saw Mr. Mukherjee did this as well. You know, use a linear trend and compare those linear, you know, just show that visually show and that those trends are different, right? It isn't as good as I work through this and think about things as doing it the other way. You can do that. It is done all the time.
And
It
indeed,
is
you
not
did it.
considered, yeah, it's not considered incorrect. But when Miss Can said addressed, is that the best model? I thought about that for a while and I said, actually, no, I think there's a better model. And now I'm convinced that there is a better way to do it.
I suppose the reason I asked you to do it was because you produced a report with and we'll get to what it all means, but the question that I had in my mind was, look at the environmental figure on page 50 of volume 7. Had this little this dip turn before what I know to be the move.
Mhm.
And so I wondered if you'd accept the proposition that whilst you may not know whether the move to a different water system called an increase or a decrease, it's not an unreasonable question to ask.
No.
Was there a change?
No, these are not unreasonable questions, and it's not unreasonable to cut up the data. I'm not saying that you asked an unreasonable question and I was happy to do it, but as I thought about it and looked at the data, I felt that we lost information by doing that.
I just wonder whether, and we'll come to what the cut-ups show, whether the exercise of doing the cut-ups helps answer that question about whether that turning point in early 14 is a real thing happening then, or an artifact of the model trying to deal with something that actually happened, and this is the hypothesis that we're testing, on the move. And so, whilst the principal technique is the one you've done in the response document, do these charts help us explore that issue, which that chart can't do to the same degree?
I'm not sure I would agree that the other chart can't do it. I would agree that I'd always agree that modeling things in different ways and exploring what happens there is very helpful to our understanding, because remember, we're dealing with retrospective data. This is epidemiology. We're not there. We're not controlling things. And so this is a very hard problem to solve, a very hard question to answer.
It's just that one of the problems, I suppose, to mention is if we go to the appendix of Mr. Dr. Agrawal's instruction letter, so that's this volume, page 242. The question you're asked is about the widespread contamination of the water system. Whilst I appreciate you didn't read the HPS report at the time describing what it is, no one is suggesting that contamination happened at York Hill. And so, in a sense, one of the two key questions that seem important from this question is, did the move to this new water system affect the experience of the patients as recorded in their data, infection rates? And so, when after lunch we go and look at the charts that you created and chop up, what I want to suggest to you is that whilst we should be careful, are they of assistance in the journey we are now on?
Yeah.
Right. I think, Lord, this might be a good place to stop before we turn to the other charts after lunch.
Yes, we'll take a lunch break. As I said, Dr. Drumright, we usually sit again at 2:00. So if I could ask you to be back then, and I hope someone will help you with lunch.
Thank you.